Dr. Ajay Sharma, and he'll be talking on Get the Best in Both Worlds, Focus Near Through Far with CRV Technology. All to you, Dr. Ajay.
Good afternoon, everyone. And thanks, AIOCMT3 to giving me the chance. And I'll be talking on the Focus Near Through Far with CRV IOLs. As we all know, we just have been talking and we know how rapid the change is for the near vision demands, and so is the change in the need for the continuous range of vision. With various lenses, what I think we have been talking and we all know about are the multifocal, trifocals and extended range of vision, but they all have some sort of a flaw. Now, for multifocal, there is a problem with the intermediate vision. For trifocals, there is a loss in contrast, higher incidence in halos and glare is there. And extended range of vision, definitely there is a problem of the near vision. Now what do we do? Now this is a technology which comes in, which combines and leverages the benefits of both the ERV and the multifocal or the trifocal technology. That is a continuous range of vision without drop or fluctuation, and there is a higher spectacle independence just like a trifocal, along with a higher contrast just like a ERV. So we are combining these two changes here. And we all know the LED, what role it plays now, and LED gives basically the emission of a shorter violet wavelight is there, and this technology blocks these high energy violet wavelengths and improves the driving vision quality, which everyone is afraid of. Whether shall I put these lenses in a patient who wants to drive? Just to show the focal range, the wavefront, how the wavefront is created in the monofocal. You can see this is just for distance. For the bifocal or the multifocal, this is the 2. And for the trifocal, you have this, but here intermediate is compromised. And continuous, again, the near vision is compromised. So here are the lenses. This just to show, this is the lens which gives you a continuous range of vision, and which is for the near, intermediate and distance. Now this lens is the Technis Synergy. It's a breakthrough innovation, and it gives a continuous vision across the range and empowers patient to see all their distances. It is a superior low light contrast also. Patient can see in all day and night. Design is just like if you see a simple Technis lens, and then there posteriorly it has the posterior diffractive surface. It has around 15 rings here. The overall diameter is 13 mm, and the posterior, the continuous 360 posterior square edge is also there. So all the similarities to a Technis which we all have implanted, it is there, and that there is the posterior side also haptic offset is there. 3 points for the 3-point focusation. And now astigmatism again is very important, which we all know, and without this no lens is complete. And we have Synergy CRV also available in toric with the Technis Toric 2 platform. Now as I have said already, it combines these two technologies: monofocal, multifocal IOL technology that delivers good distant and near vision and pupil independent design, and Technis Symphony, which is a continuous range of vision. It has limitation in the near vision, which can be done by the multifocal part of it. It has a chrome align technology, and it is a pupil independent design. Just to show the defocus curve, how nicely you can see this, and this is going to tell you why. I'll be telling you why to choose biometry which is either emmetrop or towards the hyperopic side, because you can see it is slightly myopic, one line, and it is slightly hyperopic. This is decrease of just 0.5 line. And throughout you can see even near vision, the 33 centimeters patient can read. Clinical pulse, I think this is more important rather than getting into the technology and what all is. It is all written there in the books and literature. So this is that minimize the post-operative residual astigmatism, because if we have to do it a normal lens, plano lens, then give only, it has to be less than 0.75 diopters, and no autorefs, avoid patient with corneal abnormalities, manage the dry eyes and all these situations prior to the surgeries. Ensure post-operative patient for the adequate expectation. You have to tell them it's going to take 4 to 12 weeks to settle down, and avoid pre-existing ocular conditions, especially the retinal conditions. A constants, again, it has its 119.3. If you are toric Technis A constant can be used. If all are using that, multifocal IL personalized A constants should not be used. And select the IL power that gives the residual refraction closest to plano or it towards a hyperopic side, not to a myopic side. This is just to show. I have emphasized more on it because we did that initially, and the company tells we did that. Few doctors did a myopic side and they had problem with the vision. Finally, when we did this emmetropic or little hyperopic, then we didn't have any problem with the vision. How do I choose my patient? Now, this is just to say, like, this is certain instances I'm showing that how I chose my patient. 52-year male patient, IT professional, bilateral cataract, works on all devices because wants a near vision also, plays golf, drives at night. So we gave the synergy and patient is happy. So similarly, patient household activity, female patient teaches children social activities, cooking, playing board games, cards and all. So we implanted this, and this again, very interestingly, 50-year patient which is myopic and presbyopic, fed up with contact lenses and glasses, wanted to get rid of glasses, where we did a refractive lens exchange, bilateral synergy, and patient was happy. Now our experience till date, we have used around 1754 lenses, synergy lenses, normal as a toric. This is some study which we did in 164 eyes where 42 bilateral implants were there. It was a retrospective study, multicentric, 7 centers were involved, and these were the results. Very good results as far as what we wanted to see in these type of lenses. Or day 7, the 6/6 vision was 106 and 1 month, 130, 6/9 was around 22 after a month. And similarly, near vision, you can see, this is what we want to show. After 1 month, 134 patient had N6 and 28 and 8. Nearly 96% had a good vision post-operatively, and intermediate vision was good, which has to be there in patients. This is just to show the data, the depiction here. Halos and glare, everyone is worried about that. We were also worried about it. We found 21 patients complained of this, and out of that, 12 patients improved with a period of 12 weeks, and 9 patients they still complain about it. And just to show the implantation, it is just similar to anything. This is just the lens, and this is how it looks like. Loading can be done as you implant a Technis lens, nothing new in that. And after the loading, it is just the cartridge goes inside the injector, and you can implant the lens very nicely in the eye, and just like a Technis lens. So implantation is very easy, no itch, no problem. You can see the lens is very well centration post-operatively, else you can center it nicely post-operatively with whatever way you are doing. And Torvik, I'll skip. Now just a few, 1 minute for the tips and tricks of a successful surgery. Pre-operatively and per-operatively. Pre-operatively, set realistic patient expectation. Strong desire to be independent, independent with a spectacle for far, intermediate, and near. That is again, and chronic grumbler should be avoided. A positive attitude is needed. And counseling is very important. Whatever you do, whether you do a femto or a phaco, and whatever lens you are using, you have to tell the patient whatever you want to do. We give this charts to all the patient to show whatever.
Dr. Ajay, can I request you to please conclude?
Just finishing. So what patient is doing, what activities, and again, per-operatively, the incisions have to be perfect, because if they are not, then we will induce astigmatism, and that can again cause problems. Similarly, rhexis size and centration has to be proper, because if it is not, then if a decentered lens, a lot of decentered lens can create a problem. And so for this, you can either use your CCC or you can use a femto, and these are certain things which you should keep in mind. And in my experience, spend good time pre-operatively with your patient, understand their lifestyle, need and help. them taking a decision. Always under promise and over deliver. Use your words wisely. Replace terminologies like no need of glasses to reduce dependence on glasses. Thank you very much.
Thank you, Dr. Ajay, for that wonderful overview of Synergy. And I think it's one of the very nice lenses delivering high quality distance intervision near. A quick question to you before I just introduce Dr. Sudhir Srivastav, and he'll be talking on demystifying monofocal plus IOL technology. So in your study, you said almost 21, 22 patients were 6'9" for distance uncorrected, and similar patients had those dysphotoptic symptoms. So do you correlate that it was because of that residual refractive error that these patients had those kind of?
Most of the patients, yes, they fell into that category only, wherever they had residual refractive errors. So most of them who were probably 6'6" and all that, very less percentage of patient complained of that.
Wonderful study. So all to you.
Okay. Do you plan to correct the residual refractive error?
It depends on the patient. If a patient is happy, because here we are talking about the distance, near and intermediate vision. So patients who are happy with the near vision and the intermediate, they might not be needing again a 6'6", and if we have it in the first eye, we are definitely going to do something for the other eye.
Because I have a feeling, because if you correct the residual refractive error, the halos and glare might reduce significantly.
Yes, but totally agree, but here we didn't try